medical doctor to listen to this topic, because even the communities we live in have known hernias, and sometimes we are traditionally managed with local herbs that I still don't know from my medical training how those hernias disappear. But it apparently appears it is only surgical maneuvers which handle them. But our dear participants, allow me you to welcome a surgeon, a person who has practiced in the rural setting of Uganda. He has mastered the art of dealing with the rural communities. He is down to earth and gentle when it comes to handling surgical issues. He has a good experience in handling surgical issues of patients, and he's well experienced and has done hundreds and thousands of surgeries. Some of them, if not majority, not for money, but to help the communities. Ladies and gentlemen, Dr. Mubezi is a general surgeon who works with the Iganga General Hospital in Iganga municipality, but as well is one of the directors and the co-founder of Hope and Healing Center in the very rural area of Kiwani, found in Iganga inside there. And the facility is doing a lot of work in helping the rural communities cope with some of these surgical issues. We commonly see these in the Busoga region and other communities. No wonder there is even a name of a hernia called the Busoga hernia. Maybe he will talk about it. But Dr. Isaac Mubezi is going to share with us his surgical experience and how you approach patients that have issues to do with hernias, and specifically the types of hernias he is going to elaborate more about. Dr. Isaac Mubezi has also previously worked with Zambia Hospital, and he has done wide activities in surgical area. Allow me welcome Dr. Isaac Mubezi to take us through hernias. Dr. Isaac, please take over. Dr. Isaac?
Yes, thank you very much, Dr. Mukembo, for such a pleasant presentation. I'm happy to be here. I'm trying to see how to share my presentation, and then we'll get it all done. Wow, what a presentation for me. Thank you, Dr. Mukembo. You've simplified already my work. Could I have sharing rights, please? How do I do this? Thank you. Let me see how to get this done. Share, where is share? Are we there? Is anyone able to see my screen? Not yet? Oh, there. Did I get it right?
You share now. You share.
Okay, let me share. Right now, share. Good. Are we there?
Yes, doctor, we are there.
Thank you very much for the introduction. I'm humbled by that. And thank you, Busoga Health Forum, for inviting me to this webinar. It's always a pleasure for me to be here. I would love to mute my video right away. I'm trying to get my screen work. As you can tell, I'm a village person, so some of these technology things some of these technology things.
Dr. Isaac,
Doctor,
I
can
request
we do slideshow?
Yes, thank you. I think my video is off. Are you able to see my screen?
Yes, your screen is seen. Can we put in slideshow mode?
All right. I'll do that. Right. Are we?
Yeah,
Is that visible to everybody?
yes, we are good to go.
Oh, thank you. Thank you so much. Sorry about the glitch in technology. I'm so happy to be here today. And as I discuss inguinal and ventral hernias, I'm pleased working in a village setting. I work at Iganga General Hospital, which is a fairly large hospital serving over 500,000 people because it's along the highway, the East African highway, but also we are surrounded by various districts. And so we get so many patients, not only from Iganga district, but from the surrounding districts. But I also am privileged to work at the Hope and Healing Center, a rural community based hospital here in Chiwan, and I'm speaking from Chiwan. So I hope my internet is good. Well, without wasting any time, I don't need to introduce myself, but allow me give this presentation as well on behalf of Professor Jacob Echo, a consultant general surgeon and transplant surgeon based in the UK. And him and I were able to put up this presentation together, but he's also my mentor. Yes, acknowledgements as we start. I want to acknowledge Operation Hernia and the College of Surgeons East, Central, and Southern Africa. Professor Jacob Echo, who is my mentor in hernia surgery, and Mr. Chris Opong, who is the chairman of Operation Hernia UK, as well as some of the images I got from Google Images and Wikipedia. But I want to declare as I present that I have no conflict of interest. A little synopsis of this is that we will have some general comments. I'll speak about paraumbilical and umbilical hernias, epigastric hernias, Spegelian hernias, lumbar hernias, inguinal hernias, and then we'll give a few remarks and we'll be out of here. Of course, I will allow questions at the end of this presentation. Well, I need to say that hernias are quite important, as already Dr. Mukembo said. Many of us have heard about hernia, and when you ask, hernia is an English word, but even you ask, if you ask my, the people right in the village, they will say, ndina hernia, I have a hernia. But it's important for us to note that hernias cause considerable pain and discomfort. But in this setting, in most of the sub-Saharan Africa, they cause economic loss, particularly to the rural population that are really agrarian and based in agriculture. And these hernias, many times are at risk of obstruction or strangulation, and most of our patients will basically appear to the hospital or to the clinic when there's obstruction or strangulation. So it's important for us to note that they're only second to appendicitis as I identifiable causes of acute abdomen. They definitely are at a risk of causing mortality. I must say that my neighbor succumbed to one, and they're subject of village ridicule and of gossip. And so it is important for us to repair them early. As I said, for someone to have a hernia of this size or bigger, of course, they will not tuck in their shorts, trousers, and the people in the village and the surrounding areas will keep referring to them as the person with the hernia or the person with the big trousers. And it is definitely a subject of village ridicule. So as you can see, our friends here, these are different patients that I worked on some time back, but as you can see, such people, they have lived with such things for years, not just for weeks, but for years. And you can only imagine the effects to the family and to the people around them. So what are some of the causes of these hernias? Usually are caused due to increased abdominal pressure, like people that have chronic cough, people with asthma, or COPD, pulmonary disease, urinary troubles, like people with enlarged prostates, people with chronic constipation, people that do a lot of straining, like carry heavy things or push heavy things, and some people that have ascites to risk of getting some of these hernias. And of course, some abdominal malignancies, and for the women, the most common cause is pregnancy. The other cause is due to the weakness of the abdominal wall, and some of these are either congenital or acquired, and the most common causes of the congenital are due to the patent processus vaginalis, which causes indirect hernias in young adults, and to the female is the patent canal of Knock, which later on, it later on turns into the round ligament if formed well, if well obliterated. But acquired, usually caused due to excess fat. Let's talk about like obesity, and those that are pregnant, for the women, some of them get these hernias. Some causes could be due to incision, surgical incisions, and the other is the connective tissue disorders like the Marfan's syndrome. So to briefly talk about ventral hernias, I have just an illustration of this picture. I mean, a ventral hernia is basically a bulge through the opening in the muscles of the anterior abdominal wall. And so the most common of the ventral hernias will be the umbilical hernias. We've seen children with umbilical hernias, but also adults with umbilical hernias, and we could have paraumbilical or the epigastric hernias. But important to note that we have what is called a Spegelian hernia that are mostly missed. And of recent, I've seen that some of our patients have lumbar hernias, and they are easily mistaken for lipomas, as I will explain a bit later. Then the other, the femoral and the inguinal hernias that most of us are familiar with. What is important to note here is femoral. Okay, I will explain that later on as we go on. But again, the risk for these ventral hernias is basically pregnancy, obesity. If you have had a hernia before, you're at risk of having either another hernia or a recurrence of those if not well repaired. And people that have had history of abdominal surgeries or frequent surgeries, abdominal surgeries, and either got septic or had complications at risk of getting some of these hernias. And then injuries to the bowel. Someone has had resection, somebody has had trauma to the bowel and had a complicated surgery. The chances are that any lifestyle, you might get one. And of course, a family history of hernias, at risk of putting due to that. But in our environment here in Busoga, the most common is, constantly lifting and pushing heavy objects. I've got questions like, how do you diagnose hernias? It's very, very, very simple to diagnose hernia, and most of it is clinical. It's a clinical presentation. You're able to see a bulge on somebody's either inguinal area or abdomen or the back, and you're able to tell, even the patients themselves are able to tell that, there's something that bulges when I have pressure or I'm coughing or I'm standing, and then it reduces back when I lie flat. You're likely to tell, if you're a clinician, that this is likely to be a hernia. But in cases where you're not sure, you can ask for an ultrasound scan, and under skilled hands, you're able to get good results that this is a hernia. In cases where there are complications, so for example, for lumbar hernias, and you're not so sure, in other communities, you're able to do a CT scan or an MRI. I must say that these last two are not common things that you should ask to affirm whether there's a hernia. The first two, clinical examination and ultrasound scan, is able to diagnose that. And the CT scan or MRI is to be asked in cases of doubt. But now that, we are developing and we are getting patients that want to be really sure, and with the development of insurance companies and the legal issues, in case you're not so sure, you can ask for those. So as you can see the picture here, I just want to show you, like, what you see here is a paraumbilical hernia. It's just above the umbilicus or the navel. So obesity, again, heavy lifting can cause some of these hernias. But in this same picture, you can see that we have not only a paraumbilical hernia here, but we have here and as well an umbilical hernia. So it occurs through the superior aspect of the umbilical scar, and they are more common in male than the female. Again, due to the work that most of our male colleagues go through, lifting heavy things and hard labor, they pre-expose them to these hernias. And the good news with most of the paraumbilical, umbilical, and epigastric hernias is that it usually contains omentum. It's in rare cases that you will find gut entrapped within these hernias. So key consideration in repairing or treatment of these hernias is the size of the hernia. If a hernia is bigger than 6 centimeters in diameter, you are safe using a mesh than having to repair it with just a suture. Most of these hernias, just so you know, you're likely to, if you don't take good precaution, you're likely to get infections, and infections usually complicate these hernias. So studies have showed that there's 11% recurrence rate if repaired, most of these big defects if repaired without a mesh, while there's only 1% chance of recurrence when using a mesh in repairing some of these big defects. The common way of repairing umbilical hernias, paraumbilical, as well as epigastric hernia is what we call a Myers repair. And this every MO should be able to do it. Most of them can even be done under local anesthesia. 90% of these procedures that I'm doing are under local anesthesia, which helps that the patient is able to go home the same day. So yes, we do what is called a double-breasted repair. As you can see in this picture, that this is the defect. When you pass through the suture, you're able to bring this aspect of the rectus onto the inferior aspect of the rectus so that you get a double breast. In cases where you think the defect is big, even after doing this Meyer's repair, then you can do an only mesh and you're sure this patient is unlikely to get a recurrence of the hernia. So this works well as the umbilical hernia. I mean, mesh repairs also have complications. However, if under skilled hands, the complications are fewer. Under unskilled hands, you'll get some of these complications like seromas, adhesions, hematomas, I mean, fistula formation, infection. If you're doing a mesh, you don't want your mesh to get infected because you'll have to remove it. So in case of using a mesh, please take extra precaution in making sure that there's no infection. There are studies that have shown mesh vis-a-vis just a Meyer's repair, mesh vis-a-vis herniorrhaphy, hernioplasty vis-a-vis herniorrhaphy. The summary from all these studies is that there is less recurrence rate in using mesh repair than using sutures. Like the study done here, you can see that some of them got a 0 mesh repair. From so far, our research here is that we've managed to attain 0 recurrence rate for the last 7 years for all the patients that we've used a mesh on. Here in Chiwani and in Iganga Hospital. Yes, so there are many randomized, control trials that have been done, and still mesh repair is the way to go. It's the standard way to go now than using tissue repair or suture repair. This happens as well for the epigastric hernia, but of much importance within epigastric hernia is that most of these have a very, very narrow neck, and they are not only missed, but they are at high risk of causing obstruction or strangulation because of the narrow neck, that the content is trapped because it just comes out through a very narrow opening, and if not well taken care of, some of the patients come really bad and obstructed. So you have to make judgment of open approach vis-a-vis laparoscopic approach. It is advisable that if the defect is small, you do not need to do a laparoscopic approach, because the 3 holes you're using for the laparoscopic approach compared to the incision that you're making for the epigastric hernia repair, I mean, it's almost the same. And so you don't need to have laparoscopic repair for a small hernia defect like an epigastric hernia. And most of this, in our low resource setting, it is advisable that you use local anesthesia. Spigelian hernia is one that is usually missed by most of our clinicians. And this is a hernia through the Spigelian fascia. And it usually occurs at the lateral edge of the rectus muscle at the semillinear line. So it is usually common in adults over 50 years of age. So due to the weakness in the fascia. This is just an illustration of where the Spagelian hernia happens. As you can see here, what we call the Spagelian hernia belt. Just measure from the umbilical plane, between the umbilical plane and the interspine spinal plane. This is the anterior iliac spine, anterior superior iliac spine, and that between there and the umbilicus is likely to occur the Spagelian hernia. And so if you say bulging around there, be careful of how you repair it. For the patients that can afford and you're not so sure of the hernia, you can go ahead and do a CT scan. Some of the differentials of this Spagelian hernia is that, you know, the patient is coming in pain, there's a bulging, and the most likely diagnosis for most people as a differential is, oh, there's an appendicular mass, or there's an appendicular abscess, or there's acute diverticulitis, and you know, so you have to be careful. And if you just tell that patient to cough, you're able to see it bulge. But the problem is that most of this Spagelian hernia, when it is obstructed, the patient is in so much pain, is bending forward, and you're thinking, oh, when I touch, it's, you know, there's a mass, and you think it is an appendicular mass. So something for you to think of as you carry on good clinical history and examination. And if you're not sure, please, you can do an ultrasound scan if the sonographer knows well the machine, they are able to tell you. But just to look at this CT scan, that is very definite. As you can see, this is the abdominal wall, and you can see the herniation right here of Spagelian hernia. Yes, so they are liable to strangulation. So whenever you diagnose a Spagelian hernia and you have affirmation it is a Spagelian hernia, it's important that you repair it because you do not want it to obstruct. There are various approaches to that: open repair versus mesh repair, or versus laparoscopic repair. If you're doing a laparoscopic, you can do a total extraperitoneal repair or a TAP, but under good hands, you can do an open repair nicely and make sure that you put a mesh, because they are likely to recur if you're just doing a tissue repair. Reason is the fascia is already weak and it is within these adults. So it's most advisable that for Spagelian hernia, please have a mesh around for you to repair it. This is an example of a lumbar hernia, and I have seen that in many patients, they are coming and, oh, the clinicians are like, wow, this is a lipoma, let's repair it. And some of them are daring to do it under local, and boom, you find it is not what you expected. It is a lumbar hernia. Again, in part of examination, just about 2 weeks ago, I got, you know, this patient, and a colleague had seen and had said, oh, there's a lumbar, there's a lipoma here. And so as the patient was lying down, I told them to cough, and these are the results of what you could see. And so examine well, try to press, is this mass able to reduce or not? Most of them, you're able to see them reduce. Under pressure, you're able to see them bulge if they are not already obstructed. And so it is something to look out for. So again, in our setting, an ultrasound scan is able to confirm the lumbar hernia. But in developed settings, you can do a CT scan. Again, a CT scan is you're able to tell on a CT scan a lumbar hernia vis-a-vis a lipoma, but just an ultrasound scan should be enough for that. What are some of the causes of these lumbar hernias? Most of them are most of the lumbar hernias are congenital, though we have some acquired ones. Through the process of the undescended test of bilateral renal agenesis and the lumbus costovertebral syndrome. For the acquired, mostly is primary non-traumatic, while some can be secondary, like traumatic, and has caused a tear through that lumbar fascia. But again, there are some procedures, like if somebody has undergone surgery, they can have these lumbar hernias. Yes, so just to show you, the position of the lumbar hernia in this. And yes, as you can see, the mesh here, the sac here being pulled out, and you can see all that defect. And the best way, it will be a plug mesh that is best to be put in this lumbar hernia. But if not well covered, if you do not have a plug mesh, please do an onlay mesh. So there have been arguments, laparoscopic versus, the traditional repair or tissue repair. The take home for this is it is due to the skilled hands. If you're skilled enough, you can do a laparoscopic hernia, the hernia repair. But in most of our settings, I want to advise us as clinicians to be able to do open repair, and it has shown good benefit. It is easy. The patient can even go back home. Though in the Western world, these ventral hernia repairs, due to the comfort of the patient, laparoscopic repair is done because it reduces postoperative pain, reduces hospital stay, and there is, of course, absence of large scar, and there's faster overall recovery. Some of the concerns of these open repairs for the ventral hernia is long post-op hospital stay and great amount of pain, especially for large defects. This, I'll just quickly go through that. As you see the layers, as you go through in considering the hernia surgery, you must respect tissue, knowing that you go layer by layer from skin to the superficial fatty layer to the membranous layer, which is the scapa fascia, and of course the deep fascia, and going through all those layers. What is important for us here to note, especially in inguinal hernia, is the external oblique aponeurosis vis-a-vis the internal oblique aponeurosis, and of course just below the spermatic cord to respect the transversus abdominis and extraperitoneal fat before you go into the end abdominal or transversalis fascia and then the peritoneum. So yeah, those are the layers you go through as you are repairing the hernia. I want to bring to your attention through this, especially in repair of the inguinal hernia. This ligament here, called the inguinal ligament, is a huge landmark that most of as clinicians should respect, because it is the toughest ligament that you want to depend on repairing this hernia. You see that the inguinal ligament is attached on the anterior superior iliac spine and the pubic tubercle. And any hernia that lies medial to the inguinal ligament is an inguinal hernia. But if it lies lateral to the inguinal ligament, then you're looking at a femoral hernia. But as we repair, make sure that you're able to visualize the inguinal ligament, and it will help much in the repair of this hernia. Another structure to look at is the Cooper's ligament, especially in regards to the repair of the femoral hernia, because you want to use those in doing a Mubezi repair. Yeah, so the inguinal ligament, as I've said, it extends from the anterior superior iliac spine to the pubic tubercle. It's very strong. It is about 10 centimeters long, and it's as well known as the Cooper's ligament. The inguinal canal is of a length of about 4 centimeters, and superior to the medial half of the inguinal ligament. And I think I should explain it through this picture that I've put here. Ascis, which is the anterior superior iliac spine, pubic tubercle. If you're considering doing local anesthesia, these structures must be respected, and you must know the anatomy of that. You just know that between the anterior superior iliac spine and the pubic tubercle, in between there is the deep inguinal ring. Why is this important? Around the deep inguinal ring are these important vessels, which we call the inferior epigastric. So as you give anesthesia, make sure that you're starting from the ascis, where you're doing your best to block the ilioinguinal nerve and hypogastric nerve. And this, if you started from here, the anesthesia here will be easy at the pubic tubercle, and make sure that you give a good amount of the anesthesia at the deep ring or the internal ring, because as you pull here, you don't want the patient to have any pain. So yes, the inguinal ligament, the internal ring, as I've said, is about midway between the ascis and the pubic tubercle. And so those are important in repairing the hernia, and it is important to know the structures that are around there. This is what I'm talking about. As you look at this, you have to look at the deep ring or internal ring, that there are important structures here, including the inferior epigastric vessels that can easily bleed if you are not aware of them. But also, yes, so as you can see, the inferior epigastrics are there. Also, you have to be aware of the femoral vessels that are coming as well from there at the lateral aspect. So in repair, please take note of those, and you will be able to do a successful repair without much bleeding. Again, I just want to emphasize the internal ring or the deep ring, that it is important for you to know where you are in repairing of that. If you are not aware of that, it's not only about the bleeding, but it's important in reducing this hernia. And those epigastric vessels are able to determine or define whether you're doing an indirect hernia or a direct hernia. If it is a direct hernia, it is medial to the inferior epigastrics, while if it is indirect hernia, then it is lateral to the epigastrics. But you must take note to always notice them as you do the repair. I would love to leave time for questions as we go on, but again, it's important to note, as you can see right here, this is the external ring, while you go into the deeper ring. I don't know whether that makes any sense as we do that. Inguinal hernias. Okay. It is important, as I said before, to note this triangle of doom. And I speak from experience that I've seen many bleed and then lose control of the hernia because it's bleeding and they are fidgeting, and then the hernia is not reduced well. They are trying to repair the vessels and it's just a mess, and you'll have recurrences. So important to note the three, the rule of threes, the 3 layers of fascia. That is the external spermatic, the cremasteric, and the internal spermatic fascia, while there are also the 3 arteries. That is the testicular artery, cremasteric, and artery of the vas deferens. And the 3 nerves, the genital branch of the genitofemoral nerve, the sympathetic nerve of the fibers to the testes, and the ilioinguinal nerve, as well as the 3 structures, the vas, the lymphatics, and the pampiniform plexus. So if you're going into hernia repair, please respect those and identify them as you do that. I want to go through the innervation of that, but I want to just you to note what is in this gauze piece is the spermatic cord, but if you take good notice, you'll see the ilioinguinal nerve just coming along that. Why would I mention that? Is that most of the people get chronic groin pain because many of us entrap that nerve as we do the repair. So make sure that you identify it and take it out of your field. If you think it is within your field and you cannot, if you think you might risk entrapping it, it is better to cut it. There's the iliohypogastric nerve. As you can see, this is the spermatic cord, but you can see the nerve, just the iliohypogastric nerve there. Yeah. Okay, so again, I think this is just to look at femoral hernias, which most of us are not aware of, but it has a length of about 1 to 2 centimeters. And it is the innermost compartment of the femoral sheath. So it extends from the femoral ring to the proximal edge of the saphenous opening, and it contains mostly the loose connective tissue, the fat, sometimes the lymphatics, and the lymph nodes. So still, it is the same thing going through the skin to the subcutaneous tissue, the cribriform fascia, femoral sheath, and so on. Important to note, as you can see, this is an inguinal hernia. It's not inguinal scrotal. It is just stated in there. In adults, if you're seeing an inguinal hernia like that, you're likely to think of a direct hernia other than an indirect hernia. Well, we can see inguinal scrotal hernia, which are mostly indirect hernias. I want to mention this, that in females, you can have as well the inguinal hernias in females. As you can see that this lady has bilateral on the left and as well on the right. Though in females, it's more, the femoral hernias are more common than the inguinal hernias. But I would love to take special note of this. One time I was telling my interns that there is a inguinal scrotal hernia in females, and I got a big laughter. But yes, inguinal scrotal hernias also happen in females, and the repair is usually the same as that in males. Thank you very much. Just to say that I'm very passionate about hernias and hernia repair, because this region is common with these hernias, and we are seeing many of these, and many patients come when they're already obstructed. And so we are raising awareness, and we are doing a workshop from the 31st of this month to the 11th of August. And it will be a hernia workshop of teaching our medical officers and surgical residents on how to do safe hernia surgery, especially, and local anesthesia. Thank you.
Wow, wow. Thank you so much, Dr. Isaac, for that presentation. I hand over to Dr. Mukembo. Okay, I think Dr. Mukembo is there. Okay, Doctor, you're here. Dr. Mukembo, are you able to handle the Q&A?
Yes. Thank you very much, Dr. Isaac, for the presentation. So I was running another meeting that had taken me off slightly. And allow me look at the questions that we were asked. Most of the presentation, most of the comments I see in the chat were appreciations from the various members. Those of you that were sharing emails, perhaps you wanted the presentation shared for you. We encourage you to visit our website. Every presentation we make here is uploaded on the website. Those of you who may want to keep revisiting this presentation live, you can always visit our BHF YouTube channel, and you can rewatch these presentations in both video and audio mode with the slides moving. And those of you who are registering for CPD points, we kindly remind you, please register your number correctly. For doctors, that number of yours don't include the hyphen. That hyperlink between your alphabetical number and the numerical number, please don't include it when you're registering. Otherwise, you won't get points on your CPD portal. So kindly register correctly using the provided link. And Doctor, we thank you for presenting from Kiwani. There are people there. There is, hello? There was a question from Mr. Ronald, who requested for mentorship in the medical camps. Ronald, I think Doctor will also add on, there is a running medical camp which has been organized by Hope and Healing Center in conjunction with Busoga Health Forum and the Association of Surgeons of Uganda. And they have made a call for those who want to be mentored and participate to register. So be free to contact us offline on WhatsApp. We shall be able to give you the registration link. There was a question from Opio Ronald. What confidence should I have that a previously obstructed hernia that later reduces intraoperatively without me inspecting the gut? Without me inspecting the gut is viable? Well, this question doesn't seem clear. What confidence should I have that a previously obstructed hernia that later reduces intraoperatively without me inspecting the gut is viable? Opio, do you mind unmuting and making it more clear? Because I'm seeing you have already opened up the person and reduced intraoperatively. Do you want to know if the gut is still viable, or you want to understand if the obstructed hernia will, because I don't know what is viable. Is it the gut or the hernia? Opio Ronald.
Hello.
Yes, kindly make that question a bit clear.
Okay, what I meant is sometimes the hernia reduces and you suspect that maybe it was obstruct, maybe it was having some bit of strangulation or not. Then in the operation, it just reduces and goes back without you inspecting the gut. So how sure can I be that it's actually viable or not? I meant the gut.
Okay, but before doctor can clarify, I thought one of your objectives of inspecting or doing that operation is to also inspect the gut for viability. Maybe doctor can throw more light. Yes, Dr. Isaac.
Yes, thank you so much for asking that question. The temptation for most officers, most doctors, is that, you know, the hernia is obstructed as the anesthesia is given, especially spinal anesthesia is given, the hernia falls back. And the temptation for most doctors is, okay, I'll go find the hernia sac, transfix it, job done. Please, please, please don't follow under that temptation. Make sure that you inspect gut. So make sure that you open the hernia sac. If the patient is awake, tell the patient to cough. And as they cough, the gut will pop out of that sac. If you are by the inguinal ring, if you've reduced it well, you're able to tell the patient to cough and the gut will come out. Please and please make sure that you inspect the gut. That is very important, because if you do not inspect the gut, you're likely to close a hernia sac with gut that is already not viable. So I advise all the colleagues that whenever you're repairing a hernia, you open this hernia sac and you see it. There's what is called a Richard's hernia, and this is mostly common in children, in infants, is that, again, because the child is under general anesthesia, you've opened, the thing falls back, oh, you see the sac, say, great, let me do herniotomy, and then you forget to see the gut. 3 days down the road, you see a distended abdomen, this child is not passing stool, and is maybe vomiting. It's because part of the gut is already ischemic, and you did not take the initiative to inspect this gut. So thank you that you've asked that question. Make sure that you inspect the gut in all circumstances before you transfix. Thank you.
Thank you, Dr. Isaac. There was a question from a member. He was asking how the inguinal hernias, how do they, he was asking, thank you for the presentation. And his question was about how inguinal hernias lead to lumbar hernias. If I got his question well, how inguinal hernias Yes, how does undescended tests and bilateral renal agenesis cause congenital lumbar hernia? And then I would like you to combine that question with why does a person keep getting recurrent umbilical hernias? That was a question from Hassan. What is the cause of recurrent umbilical hernias? And why do undescended tests and bilateral agenesis lead to congenital lumbar hernias? Dr. Kindly respond to that, to those two questions. Hello, Dr. Isaac. Hello.
Sorry, I unmuted. Yes, thank you very much. Let me start from the last question, the umbilical hernias, why they keep recurring. It is technique, nothing else but technique. Make sure that you do a proper Myers repair. What I have seen for most of the people, you're not able to visualize the rectus and you're trying to repair a hernia. No, please make sure that you make a good incision, visualize the rectus well, inferior and superior. After you've visualized the rectus, visualize the defect. Make sure that you mobilize off the hernia sac of that rectus and throw it back. Be able to see a hole around it. Be able to see the hernia, the hole around it. After you've done that, then extend the rectus, like make a nip through the rectus, because this is the hole. Make a nip through the rectus so that you have now two ends of the rectus. There's the superior, there's the inferior, and then bring the both together. If you're just joining two together, there will be a recurrence because still it will tear through. But you're joining one rectus to make a double breast together, and then you'll avoid the recurrence. Thank you. The first one was how lumbar hernias are caused. Like I talked about the patent processus vaginalis. This is through embryology. If you're well aware, is that the process of vaginalis is formed around in embryology about the 8th week, and around the 3rd trimester, this process vaginalis exits through the inguinal canal, and then it is able to go through the scrotum by the time of birth. And so the cause of hernias is due to the failure of obliteration of this process vaginalis. And so it's a movement along that. If you've learned the embryology of how that processus vaginalis transcends through the inguinal canal, if that is not happening due to weakness of the connective issue, tissue, and weaknesses of that, if there's failure of obliteration, then it will cause either the undescended test, or it will cause the communicating hydrocele, or it will cause the congenital indirect hernia. And if that fails, then some of these lumbar hernias. So it's around the failure of obliteration of the process vaginalis. I don't know whether I have answered your question.
Thank you very much, Doctor. Well, that was a his take. I don't know, maybe he can unmute and tell us if at all he's contented with the answer. But I guess you get, for me, the explanation is adequate because he was asking how the umbilical hernias develop from a defect of undescended testes. Then we have a question from Sharon. Is it true that umbilical hernias can burst, hence affecting the abdominal organs? I mean, rotting, resulting to a burst abdomen and death. Sharon is asking whether umbilical hernias can complicate into a burst abdomen and death. And then Mr. Johnson was asking, Doctor, kindly talk about abuse of non-absorbable versus absorbable sutures in hernia repair. Yes, abuse of, about use of non-absorbable and absorbable sutures in hernia repair. Thank you. And then what confirms a non-viable gut? Doctor, kindly answer those three questions and then we wind up. Thank you.
Use of absorbable sutures versus non-absorbable sutures in hernia repairs. It depends on the hernia you're repairing. If you are repairing an umbilical hernia in an infant, I mean, again, depends on the type of hernia you're repairing. If you're using, let me first start from, if you're using tissue repair, that is short disc repair in an inguinal hernia, irrespective of whether it's a male or female, adult, young, you could use even a non-absorbable suture. But if you are doing other repairs, you want to use okay, you can use absorbable suture in tissue repair like short disc and all that. But if you are not using a tissue repair, you want to do a non-absorbable suture because you are attaching this to a hard tissue. If you're repairing umbilical hernias, please, ventral hernias and any other kind of hernia, and you're using sutures, please, we advise that you use a non-absorbable suture. But it depends on the defect, the age of the patient. Okay. What else? Umbilical hernias burst abdomen, can they cause that? It is the reverse. Usually burst abdomen, complicated incisions after what? Abdominal surgery could cause incisional hernias. But a umbilical hernia, unlikely to cause a burst abdomen unless you've really gone through the gut. Thank you.
Thank you very much, Dr. Isaac. To our participants, we beg that we pause for today about this topic in the interest of time. But I want to assure you, we will be presenting another section of hernias next week on Friday. It will be about children hernias. So some of these questions, like the question which is cross-cutting, like postoperative care for hernias, it will still come back next Friday. So I request you forgive us, and we have these questions, some of them, done next Friday in the presentation. Join me to thank Dr. Isaac, who serves the village people, common man, in having spared this time to give us such a presentation on hernias. And still feel free to inbox us or him on WhatsApp or on the contacts which are always provided on Hope and Healing Center website or their Twitter handle. If you have any of the questions relating to Hope and Healing and maybe hernia camps they organize and other surgical camps, they will answer you on that handle theirs, and there are very many platforms. We want to once again thank you for joining us this today. And those of you who are getting challenges registering, the link has been shared several times. And those of you who had issues with how do you register, we kindly sing once again. Please, when you are writing your number for your MDPC, don't put the dash in between the alphabet number and the numerical number. Write it the way it is, because we upload your registration sheet the way it appears, spreadsheet, it's uploaded into the UMDPC website. So the computer will only pick correctly registered numbers, and the points will automatically be put on your dashboard. So for today's presentation, you expect the points to appear on your dashboard next week before again another presentation comes. If you have any issues with CPD points, kindly inbox me or Desmond, and we shall help you out with that. Allow me thank you again for choosing to be with us today, and thank Dr. Isaac for sparing time to give us this wonderful presentation. And allow me also, we have taken long without hearing from our director, chairman, Professor Waiswa. Your voice has been lost from our members for long. Kindly thank our presenter and wish us a good weekend. Professor Waiswa Peter.
Thank you so much, Dr. Robert Mukembo, and thank you for providing voluntary leadership to ensure that we improve our knowledge of healthcare through CME. So I thank you and your committee members. Thank you for doing that together with the other BHF staff. Isaac knows is one of my hero health workers, and his health center is near my village. So I visit and I also send people from my village for him to work on. I mean, I always talk about him, about his amazing commitment. So I think you had lost me. Can you hear me?
Yes, we can hear you.
Yeah, yeah. So actually, I'm not in Uganda, although internationally better where I am, but not completely so. And the reason I've been missing in the CME because I've always been caught up either traveling or in something important for Busoga, for the Uganda and for the. So otherwise, Isaac, thank you so much for your commitment to advancing knowledge, but also for service. Thank you, and we are very appreciative of what you do for Busoga's Forum and for the health workforce, but also for the community. Thank you so much. And for members, please continue attending. As Robert says, we would like to get more people presenting. We would like to see nurses come and present. We would like to see clinical officers, people in public health, in other fields. If there are experts you want us to bring, you can always suggest those names so that they can come and present. Thank you, and God bless.
Thank you, Professor. And we keep asking God to give you protection wherever you are for your visionary leadership and mentorship that you give us, the young practitioners. Members, we usually award our certificates to presenters, but since our presenter is coming back next week, next Friday, we shall award the certificate at once when he completes the presentation on hernias. Allow me to wish you a wonderful weekend, and as well invite you to join us next Friday, same time, 8 p.m. to 9 p.m. Thank you very much. Have a nice weekend.